many new organizations on as part of this presentation today. So with that, I'll quickly run through our agenda. I mentioned the majority of you are going to be on mute for the presentations that we have starting today. If you have questions, please do use the chat feature. Thank you for keeping yourself on mute as we get started here. I'm going to take a minute to make sure we minimize our background noise. So we're going to start out. I'm so pleased that we have today joining with us Dr. Terry Fulmer of John A. Hartford Foundation. We were pleased to see this was so timely. As I got my health affairs blast in my email inbox, I saw, oh, that's so great that we have an article right around our topic, actualizing better health and healthcare for older adults. We have a longtime participant, Mike Curliand, representing West Health and talking about how e-consults being incorporated into PACE programs. We are pleased to have our folks from UC Irvine. We're going to get a little bit into the nuts and bolts of the question that comes up so many times on our e-consult work group calls. How do we bill and how do we incorporate e-consult into our workflow to be able to achieve reimbursement? So we'll ask our UC Irvine team to cover that. We are pleased, those of you who are in California have been following, I'm sure, State Bill 365, which was to promote reimbursement for e-consult, particularly for requesting and treating providers in federally qualified health centers. We're so pleased that that passed in Senate Health Committee earlier this week. We have Michelle Canales from Senator Ana Caballero's office to speak a bit around updates to State Bill 365. And we want to remind everyone, I'm sure you get our monthly blasts around e-consult news. We have a free e-consult CME opportunity available to any provider who'd like to achieve CME credits. That is happening next week. So just a reminder to share that with your contacts, just an opportunity to learn about best practices in optimizing e-consults. So with that, I think I'm going to hand off to Dr. Fulmer. And Terry, as we know, is president of the John A. Hartford Foundation. She's going to speak to her recent publication on actualizing health and healthcare for older adults. Terry, I'll let you introduce yourself, make sure that you're off mute, and I'll hand off to you. Go ahead, Terry.
Thank you so much, Libby. What a pleasure to get to know you through this process and to follow this really exceptional work. And I'd like to also say how pleased I am to be with my co-presenters today. And I know I'll learn a lot. Our foundation works with West Health, which is a pleasure. And we certainly are big fans of the UC system and also the wonderful master plan in California for health for older adults, which is visionary. So delighted to be with you today. And I'd like to talk about our vital directions and the critical nature of e-consultation for a path forward for health for older people. Next slide, please. The John A. Hartford Foundation is located in New York City. We have been here since 1929, and we are dedicated to improving the care of older adults. We do that through three priority areas, which include creating age-friendly health systems, because we believe that we don't have an age-friendly health system right now. And we believe an age-friendly health system should start at your kitchen table and get you back there, whether you need home care, nursing home care, no matter where you are. If you're getting health in prisons, if you're getting health in homeless shelters, age-friendly care. Support for family caregivers. We know that there are over 40 million family caregivers out there doing their best. COVID has certainly made it excruciating for them during the pandemic. And we know that so many of them are saying, what do I do now? Particularly those caring for older individuals with memory impairment or dementia. Then we also are very devoted to improving serious illness and end-of-life care, and making sure that we know the values and preferences of older adults and that their families know their values and preferences. Some of you may have seen the PBS cast we did last night on Fast Forward related to conversations about age and aging. And if you didn't, it's available on our website, and we're very pleased about that. Next slide. Thank you. So let me first acknowledge my remarkable co-authors on this paper. Dave Rubin from UCLA, John Arbach for Trust for America's Health, Donna Fick from Penn State, Colleen Columbus from Indiana, and Kim Johnson from Chicago. They really just did a yeoman's job working on this paper. In 2016, the National Academies of Medicine created a paper called Vital Directions, and it was to advise the new administration, be they Republican or Democratic, about what to do for care of older adults. And this is the second round, Actualizing Better Health and Healthcare for Older Adults, Vital Directions 2.0. And the whole notion of this paper is to say, with an incoming administration, what are the things that have to happen right away? And this is the nature of this advisement paper, which was led by the National Academy of Medicine and published in Health Affairs as noted. Next slide. So what were the 6 major recommendations made in this paper? And the paper is open source. Anybody who would like it, it's free for you to read. The 6 recommendations were as follows. We have to create an adequately prepared workforce. We have to make sure that our workforce pipeline is not only intact, but gushing when we think about the demographics that are coming up because of the success of longevity in our country and our world. But creating that adequately prepared workforce is absolutely essential for the well-being of not only older people, but their families and society. We know that we've seen a lot of kind of horrific challenges in nursing homes during the pandemic. And we also know that those individuals working in nursing homes, predominantly women of color, are those who are not making even minimum wage, and that they often do not have a salary that is above the poverty level, may not have any benefits, and they may not have any paid time off. Strengthening the role of public health. It's well noted in the literature now and in the newspapers that we have gutted our public health system over the past several decades, and that it is really vital that we make sure that our public health system is there, ready in our communities, in our towns and villages and communities, to be ready partners in the entire age-friendly ecosystem, age-friendly health system. We need to remediate disparities and inequities. COVID laid that bare as well when we think about the disproportionate number of people of color who were infected with COVID and the individuals who died. So thinking about disparities, inequities, making sure that everybody has a fair shot at equal health and equal health care. And we're talking about older individuals in particular, their caregivers, and in fact, of course, all of society. We have to develop new approaches to care delivery, e-health, e-consults, virtual care, all the ways that we can make it easy. And I'll talk more about that in a minute. We have to develop and allocate resources to palliative and end-of-life care. We have to continue to teach the public that palliative and end-of-life does not mean we're walking away from your care. It means that what we're doing is providing the care you need for your goals and preferences, and making sure you are comfortable, that we're ameliorating any symptoms that can be eliminated, and that you understand what your choices are when you think about what you want at end-of-life care. And again, I refer you to Fast Forward as a really good model for having those discussions. Also, we need to redesign long-term services and supports. Only 1.5 million older adults live in nursing homes in this country. One could also say 1.5 million, which is less than 0.05% of the population of older adults. Having said that, they were the people, 30 to 40% of the deaths during COVID that had to do with a lot of factors related to lack of PPE, a lack of staffing, a lack of really understanding how the infection was being spread in the early days, and also through the really unbelievable sadness that came with the social isolation that came along with having visitors and families not able to join them anymore. So these 6 recommendations are fleshed out in detail in the paper, but I think you can agree with me that this workforce, public health, disparities and equities, new approaches, palliative and long-term services and supports are headlines for what we need to do for older adults and our society. Next slide, please. So what are some of the approaches to change, and a summary comment that I might make? Well, there's a wonderful book that was written in 2015 by a physician, Eric Topol, who's quite a visionary. And the book was called The Patient Will See You Now. The Patient Will See You Now. And what Eric wrote about was that the paradigm is now shifting, and shifting much faster after the pandemic, which is it is no longer going to be acceptable to any of us to have an older person who may be in a wheelchair, who may need a walker, have to find a way to get, I'll use a city example than a rural example. I happen to have grown up in a rural community and I live in New York City. So in the city, if some older person has to come down 5 floors to find transportation, to get across town, to wait in a clinic, to be seen and maybe waiting a couple of hours, is that really who we want to be as a society? No. And thinking about the people who would be able to get any transportation they wanted, well, even so, do they really need to go through all those gyrations to be seen when we know we have perfectly good ways through e-consultation, e-health, telehealth to do this? I say absolutely not. In rural areas, I grew up in a town of 300 people upstate New York and in the Adirondacks. And right now, I'm thinking of family members who, if they need care, they would have to call an ambulance, and it's probably going to be the firefighters and medics who come first, and be driven for about an hour in order to get to the closest hospital. And maybe they could have done that all by consult. So we have to think of it differently. Paradigm is shifting. The patient will see you now. Let's think about what's right for the person and then figure out the health system around them. And that's what we're talking about, e-health. We can't revert to the past. We can't say, well, we did that during the pandemic, but we're going to go back to normal. No way. Nobody's going backwards. And as a practicing nurse, I will tell you, nobody's going backwards. So lessons from the pandemic have changed consumers forever. And we say e-health, exclamation point, e-health. And I really want to call out the wonderful work going on by Darren Anderson and the Weitzman Institute, where we've really seen data that's very compelling about the fact that 35% of all primary care patients are referred to specialists, and what you can do to avoid consultations when you use e-health in the most important ways that make it easier for older people, their families, and for all of us. So I think we're in a new moment. You all know that. I'm cheering on. I've been a big fan of this since its inception, and I look forward to learning from all of you during the course of this seminar tonight. And so I turn this morning for you, it's afternoon for me. So back to Libby.
Thank you so much, Terry. And I encourage the group to use the chat feature to send over any questions for Dr. Fulmer. I will take a look at chat. We have such a large number on. I'm not going to open up to verbal questions. It's a little too hard. So please, if you have a question for Dr. Fulmer, send it via chat. And my question for you, Terry, is when you think of, I loved your recommendations, and actually I have a twofold question. The way that these align back to e-consults, well, there are many ways, but the two primary ways I saw your recommendations align back to what e-consult is around education, and then second around just how we re-envision or look at new approaches to healthcare. So yes. Can you think of just any thoughts on how you imagine how we might have peer-to-peer or curbside consults as a benefit to educating providers around care for older adults? Do you have any thoughts on that?
I do, and I think that when we think about our educational strategies, students who are becoming nurses, physicians, social workers, all of our therapies need to learn e-health right from the start of their curriculum. They need to be engaged with clinicians who are participating in this work. They need to know how to do it ably. They need to be able to demonstrate the competencies that make them appropriate caregivers using e-health. And we need to make sure that there is a way for them to see themselves in this work. And we also have to make sure that we're working with all of our boards that certify people, or the boards of nursing that provide licensure, that this is a part of all of that. And also we have to role model as faculty and as clinicians, senior clinicians, about the value and the way in which this is working. Everybody will immediately go to the payment structure. And I was on a program yesterday where the conversation was, why do we talk about value-based payments when we should talk about value-based care? So we're talking about quality of care. And we need to make sure that we're working with Congress to ensure that the appropriate compensation is there for the right care. That's the triple aim.
Thank you, Terry. I was reading a comment that came in from Dr. Palin. Thanks, Dr. Palin. We know that there are definitely challenges in terms of uptake. And Terry, you've probably gotten the gist of the fact that when we talk about e-consults, with our work group, we're talking about peer-to-peer telehealth. So a primary care doctor asking for specialist advice. Can you think of any advice? This is sort of a different model. It's something that not everybody understands immediately. Do you have any recommendations for how we might incorporate this new model into care for the older adults?
Yes, and thanks for sharpening that question, Libby, because everything I've read about the work really is clinician to clinician. We have spent the last decade plus training people to hand off to specialists. And now we're saying that the specialist can be back to the primary care person. And we've got to get a new rhythm to it, Libby. I think that as I just mentioned, looking at the work from the Weizmann Institute, we're seeing progress and we're seeing data that would tell us that this is really an important way to go. I'll also say that where I have seen a lot of practice upstate New York in rural areas, you can't get a specialty. You must use e-consults in the emergency room, in day-to-day practice, in the examination of the data you have in front of you. So I think that we just have to keep consistently improving our processes, our practices, getting the science right. I like Dr. Palin's point about making sure that research is right with us as we think about this work. Also, does everybody need a specialist? That's an open question.
Very good point. And you bring in your knowledge as a nurse in addition to running the Hartford Foundation. So thanks for bringing in that insight in terms of change of workflow and process. So with that, Dr. Fulmer, we just really want to share our appreciation for your time today. Thanks for joining our group. We hope you can join us when it works for your schedule. And with that, I'm going to hand off to Mike Kurland. So Mike, if you could take yourself off mute, feel free to share your face if you're able to do that.
Sure, I'm here.
Thank you again. And I'll hand off to you, Mike. You can just tell me when to advance slides. Mike Kurland,
Sure.
representing West PACE.
Sure, thank you. And it's a real privilege to be presenting after Terry, by the way. So thank you. And also with the folks from UC, I feel like I'm surrounded by family being here at West Health. We do a lot of work with Johnny at Hartford and the whole UC system. So pleasure to be here with you and the Econsults group, Libby. If you can, next slide, please. So folks, if you haven't heard about West Health, just a quick summary about us. We're a nonprofit organization, nonpartisan. We're focused in on helping the elderly and really also addressing a small thing called the cost of healthcare too. So just those two things, I think we have enough work to cut out, that's cut out for us for the rest of the millennia. Next slide, please. So before I was at West, I had embarrassingly never heard of West Health, but I feel even more embarrassed that I've been in healthcare for 20 plus years and I never really heard of PACE organizations. And they have been around. I think that the roots come from FQHCs actually. But PACE stands for Programs for All-Inclusive Care for the Elderly. And there are a few things that really set this type of care delivery model apart. Right now, it's pretty small. There's only 31 states in the country that have PACE organizations. There's only 138 of them and only 55,000 participants. They call their enrollees participants, and they don't call them patients, and I'll tell you a little bit more in a minute. It's a really collaborative and interdisciplinary type of model of care. Imagine having a day center where you have like activities for folks. You also have meals, you have spiritual care, and then you also have a health clinic within it that includes a PCP, includes nurse practitioners, nurses, social workers, recreational therapists, occupational therapists, any type of therapy. It also includes pharmacy as well. And these organizations are responsible for the care of these enrollees. And this is where it really kind of differentiates. These folks are 55 years old and above, and they would all qualify to be in a nursing home. But the goal is of the PACE organization is, one, to keep these people at home, out of the nursing home, and cared for in any way that they possibly can for 24/7 out of the entire year. And they do it at 100% at risk. Yes, full risk model. The PACE organization takes on 100% risk. They're paid by Medicare, Medicaid, and they need to do things like they need to make sure that the patient has their specialty visits. They need to make sure that, in case the person needs an air conditioner to help them stay healthy, or a ramp, anything that helps their well-being or health, the PACE organization is essentially on the hook for it. They are 100% at risk. And the way they do this is, they have this interdisciplinary model, and they also make contracts with other organizations like specialists as well. So imagine being like the payer and provider, and you're getting just a certain capitated amount of money from Medicare and Medicaid. Not every state is suitable because of the Medicaid restrictions, but more and more states are becoming better suited for PACE. Next slide, please. So, everyone's going to look back at 2020 as a tipping point for telehealth. And thankfully, our PACE organization is a little bit even more unique because it's one of a few PACE organizations that actually is tied to a research arm, and that's the West Health Institute, where I hail from. And before the pandemic, we had started doing due diligence to incorporate telehealth into the PACE environment. And one reason is because for me as a telehealth proponent, when you're 100% at risk, I think that is the perfect environment, almost like a playground for things that can help alleviate any kind of unnecessary trips to the ED, any unnecessary trips or transportation to the clinic, or any kind of unnecessary interaction. And this is where you could throw in innovative models that include e-consults, video visits. You could even throw in things like artificial intelligence, and I'll get into that in a moment. But right at the beginning of the pandemic, we were fortunate enough to have already done some due diligence around e-consults, telespecialty, video visits. And right when the pandemic hit, we took what was about a 6 to 8 week process typically and just flipped the switch on for all these services within 1 to 2 weeks. My cautionary tale there is probably something that everyone else really is aware of already, is just you have to be very aware of the capacity for change. Although these services might be needed and a very good idea, there's only but so much change that you can kind of squeeze in at one time. And I'll briefly go over each one. The provider to home, we had basically a patient care assistant go to each participant's home that required a video visit. Yes, very difficult to scale because you are requiring, putting one of your PCAs, EMTs, or some resource in basically a Prius and send them over to the participant's home. But what that did was it helped us alleviate bringing the participant through an ambulance or a van into the clinic, at which point we weren't really allowed to see people in the clinic at that time. We also enabled telespecialty visits. By the same kind of process, we would have a PCA go to the participant's home, and we would have like a telecardiology or a telepsych visit. And these were visits that really had to happen with the assistance of somebody next to the participant. Like they needed some vital signs. They needed to help maneuver the participant in certain ways for the assessment. So you really needed somebody there right next to the participant. And one reason why we sent somebody out is because we didn't want to deal with the wild, wild west of using someone's own devices, their own network, and you would just include so many more variables that way. If you think it's operationally heavy to send somebody out, it's way more operationally heavy for the support model that you need to be able to manage this vulnerable population remotely. It's just a tremendous lift. We incorporated tablets also that have some artificial intelligence and with a person behind it as well. Basically, for our most vulnerable patients that were depressed, we had a subset of tablets that had this software that basically, when I first read about it, I was like, I'm a little, I don't know about this, but apparently participants love it. There's a dog or a cat that they could actually pet on the screen, and they could talk to it, and the dog or the cat talks back to them. But if at any time that dog or cat sees something that falls out of parameters, or if there's some kind of interaction that doesn't seem in line with the participant, a person behind the scenes really does more of the communication. And if they believe that the participant is decompensating, or if there's something else that's going on, what they'll do is they'll contact the PACE clinic. And what will happen is our provider team at the PACE clinic will kind of swap with that puppy or the kitty. The other thing that we incorporated were phone calls on a daily basis, which really, really helped. And it's kind of like your bottom line efforts, but they work. Those phone calls, they still work really well. And one of my favorite things, and also if I add to my list of like things that, man, I should have known about before, is Econsults. And this completely changed the game for our specialty visits and for our telespecialty visits. So we were able to minimize the amount of transportation efforts. And it's not only transportation too, a lot of these participants require additional staff to go with them. So we had resourcing for like basically labor, and we had resourcing for transportation. And sometimes you take a van out and like a CNA, for instance, they might need to stay at that specialty visit for maybe 2 to 3 hours. And that takes that whole van and that CNA out for the entire time just for that one visit. And the visit might only last about 15 minutes. And that visit was maybe a follow-up visit, or it may have just been medication adjustment, something that there's several types of visits. There's ones certainly that require a lot of hands-on, but then there's other ones that require just a few simple questions to be answered. And the ability that Econsults gave us was to completely relook at who we send to specialty visits. And I'll get back into that in a little bit. So some of the key takeaways with our Econsults implementation, and this is for folks, if you've already implemented, great. If you're thinking about it, I highly recommend it. We went through a process where we looked at many different vendors, like probably some of the premier vendors that are out there right now. And where we ended up was with an organization, not necessarily just based on price. And I think a lot of folks do focus in on the dollars and cents, but really it was the confidence that our clinical team had in the ability of that other organization to be able to provide the consultative support in a certain amount of time. And I'll give you an example, like just one situation stood out, very, very good company, but this one company didn't provide you the name of the specialist. And my clinical team was completely against it. They said, we don't feel comfortable, working with an organization, no matter how good they are, unless we know that there's a provider's name attached to it. We may never reach out to this person, but we need to see a name. We need to know that we're working with another provider, and that name is kind of like this comfort zone. And the other thing is and the simplicity of the implementation. Basically, like these organizations that we talked to, they heard the concerns of our providers and kind of like the workflows. And we ended up choosing an organization that we could work with that could implement anything from fax all the way up to an integrated platform, highly automated solution. So, my goal as the operational lead there was to find an organization that, had the confidence and that had the simplicity there. The other thing is, like, once you have the tool, and I don't know if organizations are struggling to get their providers to use this, but just like anything else, the provider buy-in is really the most important factor for success here. Could be a great tool, could be super simple, and ultimately, and each organization has their own culture, but I've noticed that when you stop and listen, I know this sounds crazy, like if you really listen to the concerns of the provider, rather than coming at it like you're the authority and like this is how something should be done, I've noticed that the threshold for acceptance and for using a new process and workflow is lowered because they've been heard, and if you're really listening to what they're saying, you're going to implement something that is a lot easier for them to integrate into their workflow. And that's just the action, but really I need to integrate the behavior and like the emotional biases. I need to kind of deal with all that stuff. And the company that we selected was also very good at that, but the operational team that also has to implement that has to also kind of portray that too. Like, we hear you and we are going to adjust whatever we can to make your life easier. So some of the other things that we've recognized in this, now the E-Consult, to me, if I'm the executive director or just like one of the administrative leads, I love that my provider group has a group of docs and nurse practitioners that they could just call up and text for that curbside. That's awesome. And, that's great. But when you're adjusting the treatment plan, the medications, anything, I need to know as the administrator of the organization, like, okay, like how and why, like, is this happening? Like, why are we changing the treatment plan? Is it like just something that we knew? The E-Consults, because it's so official, it's basically, we get a written report, it gets plugged into the EMR. There's a name attached to it. We see the directions. We also see the question that was being asked. We have all this, and the provider, not just the provider that's texting their colleague, gets the information, because right now if you're doing curbside, it's a one-to-one. But when we get the E-Consult, that gets uploaded, and all the providers, including the nurses and the CNAs, everyone that's taking care of that patient has access to read it and review it. And the other thing that's happening when we have this information is that the skill level and the knowledge of our own clinicians is growing because we have this documented consultation, which, I thought, great, let's get rid of the curbside because of like it decreases risk, but I didn't really think of all the upside to it. let's see. Yep, I'm probably taking a long time. Sorry, Libby. So just a little bit of context, and this supports some of this conversation that Terry had earlier. We're going to have a tremendous shortage of clinicians, especially specialists. So like we cannot keep doing the same things that we are doing. And our primary care folks, our PCPs, or nurse practitioners, our family practitioners, they're going to need to incorporate new processes that help them deliver the care that they need for their patients. And that doesn't mean sending that patient to a specialty appointment that might take weeks or at least days to get in front of them. And then they got to get the report back. And then the PCP then has to follow up with the patient. All that takes too long, especially if you have simple questions to ask. The other thing that's coming around the corner is you're going to have less PCPs. Nurses, the jury's still out, depends on what state you're in. And this is all by 2030. And the thing that really, really frightens me, but it kind of like plays into like the demand and the needing for services sooner than later, is that you're going down from 7-to-1 to 4-to-1 unpaid caregivers per person. So healthcare in general does need to change. Next slide, please. In general, like everything's costing too much money. So like as by 2030, the regular family is going to pay 10K, but your employer is going to pay like about 22K per beneficiary. So in general, you're going to need to find ways to decrease the cost, and Econsults is another strategy in doing that. Next slide, please. Other things like value-based care. I know we talk a lot about it. Just in general, you're probably hearing a lot about it. But these models, if you're not doing it now, I highly encourage you to start looking at it now, because a lot of organizations, including payers, are starting to look at these value-based care models, these risk-based care models, as insulation from the next kind of pandemic or the ups and downs of seeing patients at volume. For the provider side, it's basically you get per member per month, so you know money's coming in. For the payer side, they're worried about the kind of like this reflex thing happening, where like now they're going to have so many visits that they're going to be paying more than they did last year. So they're looking to know how much money is going out per member per month. They like steady, they like calculation. So it works better for both parties if you're in this value-based care model. Next slide. Remember that every implementation is only successful with iteration. It's not going to be perfect out of the gate. And during the Q&A, if you want, I could tell you about our hard-learned lesson there with that one. And really understand what kind of organization you are. This past year, many organizations had to take a really good long look in the mirror and decide whether they are the reflexive type, or are they the kind that sit down and rethink how they deliver care. If anything we've learned, being reflexive is a lot more expensive and harder to do. And as we look into the 2030s, it really is time to rethink how you deliver care. Next slide, please. Just some resources that if you want free resources on westhealth.org. And that's really it. I look forward to any kind of Q&A.
Mike, that was so informative. And I love your slides, just really make us think about how we can incorporate Econsults in a different setting. It's just so helpful. As questions come in, I will bring them back to you throughout the course of our call. I don't see any yet, so I'm going to move on to our next presentation. But if there are questions for Mike, please do share them by chat. And Mike, thank you so much for always being such a great part of our work group and for your time today. And with that, I am going to ask Kathy LaPierre and Valerie Dixon of UC Irvine to unmute themselves. And Kathy, I am going to let you share your screen. I'm going to stop sharing and let you share. And let's hope that you are on okay. There you are, Kathy, great. And Valerie, nice to meet you both, or nice to have you both. I've met you before. Thanks for joining us today. Kathy, are you okay sharing screen? Let's make sure you're unmuted, Kathy. And Valerie.
Yes, Kathy's working to come back in. Her audio is
her audio is a little bit spotty. So I just wanted to introduce Kathy. She's our compliance audit officer. She is really our SME, dealing with issues as far as billing for e-consults with Medicare. So I'm going to step away and turn this presentation over to Kathy.
Great. How are you doing, Kathy? You're on okay on audio? While you're getting set up, Kathy, I'm going to set the stage for why we asked Kathy and Valerie to join us today. So over the past couple of years of working together, 5 or more years working together with this group, we've always wondered, how do we move Econsults into all different settings for all patients? And how do we help to ensure that providers are billing for Econsults and getting reimbursed? So Medicare has posed a lot of questions. How do we do this? And that's why we reached to Kathy and Valerie. Kathy, let's make sure that you're on audio. Are you okay now?
Okay.
Yes.
Can
good.
you hear me now?
I can. And can you share your screen, Kathy?
Sorry.
No worries.
I will do that. And I've got a couple of screens to share. So we'll start off with this one. There it is. Okay.
Great.
Awesome. So I want to thank you for having Valerie and I here today to speak to you about Econsults. This is something that we have a project team that's been working on this since the inception, which was in 2015. They brought compliance into that a couple of years later. UCI Health, in case you don't know anything about us, is an academic facility. We are associated with the University of Irvine, the University of California at Irvine. We have a 417-bed acute care hospital that provides inpatient, outpatient, reambulatory, special medical, behavioral health, and rehabilitation services. So we kind of see everything that goes on throughout our medical center. We have the Chow Family Comprehensive Cancer Center, H.H. Chow Comprehensive Digestive Disease Center, a neuropsychiatric center, regional burn center. We are the only level 1 trauma center and level 2 pediatric trauma center in Orange County. We are the region's only high-risk perinatal, neonatal, and maternal fetal natal transport system. We have a great facility for all of those areas. To toot our horn again, the Chow Family Comprehensive Cancer Center is one of 51 National Cancer Center Institutes, and the only one again in Orange County. We have 170 physicians that are recognized as physicians of excellence. For the U.S. News and World Report, we are number 10 in California, and for the 19th consecutive year. So we have a great institution, and our physicians are extremely dedicated to what we're doing. So saying that, one of our physicians, and I will stop sharing this particular screen, Dr. Amin from the Department of Medicine, he's the chair of Department of Medicine, spearheaded this project, like I said, back in 2015. And we are, and I'll go ahead and share this piece of my screen. Okay. We have actually been billing for Econsults for a while now. Of course, we did it department by department. They determined that Econsults would really help generate some more income for the physicians for work that they actually technically probably already do. The doctors were interacting with each other to answer questions, and now they found this venue that they can actually be compensated for some of those questions. It also frees up the time for inpatient visits that maybe not, or in-person visits that may not be necessary. So that way, if a simple question can be answered and the primary care physician could deal with that answer and take care of that patient, then they may not have to see that specialist. Excuse me. And that would free them up to see the more complex cases as well. And so we brought these into, so we started them out department by department, did a few departments at a time. A lot of that had to do with getting the departments on board, getting the IT in our electronic health record, there was some setup time. So you had to have the templates cross over to the way they needed to be and all of that. I'm not technical, so forgive me for all of that. But you can see here, we track it by how many we've done. So overall, we've done 2180 e-consults since the inception. And you can see here on the average response time for the ambulatory e-consults, we have a couple of outliers that took about 3 days, but you can see overall our average is only 1 day to have these e-consults and these questions answered. And there were some of the physicians were concerned about whether or not they needed to see the patients. And so if they felt that they couldn't answer the question without seeing the patient, they converted it to the inpatient or the in-office visits. So there was no problem with that. It wasn't like we were forcing e-consults on them. They had the choice if they could do the questions. And so our success rates, we've tracked that in percentages, and you can see that we have an 81% success rate for e-consults and getting them answered, which they feel is fairly decent average at this point. And I will go here. So then we decided to ramp up specialty to specialty e-consults. And we have, these are the departments that we have done there. It's going very smoothly. We have 281 completed e-consults from the specialist to the specialist. 63 of them were converted to in-person visits. And so our success rate here for specialty especially is 78%. So again, they're very happy with the way that this is ramping up. We have just recently started inpatient e-consults. And so these are the few departments that are doing these inpatient services. 249 of the e-consults were received. 114 of those were converted to in-person visits, just based on the patient's issues and the questions that were asked. So we have a 54% success rate for that. The inpatient response time is only 3 hours and 30 minutes. So that's actually really not bad. They're answering them fairly quickly. The departments that are involved in this in the inpatient side were involved in the ambulatory side also. So they were kind of aware of what was going on when that happened. So now I'm going to stop sharing this slide, and I'm going to give you kind of the nuts and bolts of what you're here to look at. I can find my slides, sorry. Here we go. Okay. Okay, so this data is from 2020. We had our billing department give us this data just recently. And I've got, these are the denials. So we've only been denied in all of 2020, we've only been denied 73 times. And the reasons for those denials depended on what was done. Some of them were just not covered. Some of them were bundled. We had several bundled, and there were two different areas of bundling that were denied. Some of them were bundled because they were billed with the actual requesting e-consult. And some of them were denied because the patient was seen within that 14-day criteria face-to-face. And so you cannot bill those together at that point. We have determined in our entity that we are only going to bill for the 99451 and 99452. Well, the 51 code is for the consultant, and the 52 code is for the requesting physician. They determined that the other codes that are e-consult codes, the 446, I believe, through 449. Those, they didn't feel that our physicians met the qualifications that were required for that. So, but they did meet the qualifications for these two codes. So you can see there. Now I'm going to shift over to, and hopefully this transfers to you as well. So the payments we've billed 327, and portions of those have been paid. You can see we've got Blue Cross pays, even out of state Blue Cross pays. Medi-Cal has paid some of them, and Medicare has paid quite a bit. So it depends on the code as to what they pay. But typically we get, for Medicare patients, we get about $32.58 or 60 cents, depending on whatever the reasons are. It looks like.
So Kathy, I had a quick question for you. As you approach the billing process, you know, just wondering how you share this with your providers to make this easy for them. Do you ask them to talk to their patients about how to explain the billing process, that their payer may send them a bill and it's going to be a small bill, or how do you train your providers on this?
We actually let them know that consent is required. And what they've done in our electronic, and forgive me, my screen seems to have gone away. So, but I don't have anything data to show you regarding this comment anyway. But what we've done to make this easier for the providers so that they don't forget, we've added the consent into our terms of agreement consents that go out every year for the patients to sign. But we also require that our physicians get that consent before they do this e-consult. So the requesting physician has to get consent from the patient. How we manage that is there is a hard stop in our electronic health record that requires them to put the question in, so that reminds them they need to tell the patient that there is a potential of payment, co-payments or deductibles or anything like that. So share of costs would be the patient's responsibility.
Thanks, Kathy. And then I guess my other question around that is the patient ever questioned you? You know, have they ever said, what did I get this bill for? I don't know what this is. Has there ever been any question or confusion?
In the time that I have been there, we have only had one patient complaint that fell around that. It was resolved, and the patient was happy at the end, but they said they were certainly shocked, but all the evidence that we had showed that the physician did actually tell the patient that this was going to happen or potentially could happen. So, but in the time that I have been dealing with this project, only one has come through that I've seen.
Thank you so much, Kathy and Valerie, and we appreciate your time on this. I think our biggest challenge has just been how to explain this to patients, you know, how to introduce a new concept, and it sounds like you're doing it very well, and great to see that it's taken off and there's no, no general challenge in terms of doing this for Medicare patients. Valerie and Kathy, I'm sorry that we are running a little bit short on time, so I'm going to ask folks to share their questions and comments for Valerie and Kathy through the chat. And I just really appreciate your time today. You've been great participants, and we appreciate Dr. Amin's sharing on our prior calls too. So we're glad to have you as part of this group. And with that, I want to celebrate. I want to take a moment to celebrate what we have had happen this week. We have Michelle Canales from Senator Ana Caballero's office on the phone today. She has spearheaded the effort to have State Bill 365 get through Senate Health Committee. And Michelle, would you like to give us a quick update on State Bill 365? Can you unmute yourself, Michelle?
Sure. Thank you, Libby. So SB 365 was heard in Senate Health Committee yesterday, and it passed with unanimous bipartisan support. The bill had no opposition. We're really, really happy about the outcome. So now it will go to Senate Appropriations Committee, where the fiscal impact will be analyzed. It's very likely that the bill will go in suspense. Suspense threshold is only $50,000. It's very, very low. When a bill does go on suspense, it's put on a list, and that entire list is taken up in like around May. So that's when we'll have our next committee hearing.
Thanks, Michelle. And we've asked this group, and we appreciate all those who have responded with support. And we know this is a California-focused ask. Those of you who are California stakeholders, many of you have already written in to express support. Michelle, is it helpful to have additional supporters at this time?
Oh, absolutely. Yeah. When support can come on anytime through the legislative session, it always just makes your bill stronger. So I did want to say thank you to those who have already signed on. I'm sure, you know, that helped us very much with Senate Health Committee. And if anyone else wants to take a look at the bill, we can put a link up. You can email me with any questions, and I can send you the back sheet. I'll go ahead and put my email in the chat.
Thanks so much, Michelle. I sent out the link to Senate Health with the updated bill language. Those of you who want to support, feel free to reach out to us. Thank you so much. And in addition, those of you who are not in California, we're happy to share this bill language if it might be helpful to you in your conversations with other states. Thank you, Michelle, for your time and for bringing Senator Caballero on our last call.
Thank you all so much.
I'm going to zip through our last few slides here with some important updates. And those of you who are providers, please take note that we have a CME free opportunity next week for any provider who's interested. This is not a technology presentation, but a discussion around best practices in Econsults peer-to-peer communications. So we're happy to have our clinical advisor, Delphine Tuo of Zuckerberg SF General, along with Darren Anderson from CHC Inc. in Connecticut, speaking to best practices. So please do join us. The link to sign up is right here. Please share it with your teams. And I'm not sure if Rafael Gomez is on with us today. If you're on, Rafael, thanks for joining us. We wanted to share that all of you are most likely on our list to get our Econsult news, our bulletin that comes every month. You can see the most recent presentation recommending thoughts on how to reimburse FQHCs, especially along the lines of Econsult here. And please mark your calendars for next month. We have April 27th, 12 to 1 p.m. Booked for our next discussion on cost effectiveness. We have a lot of questions around Econsult and cost savings, so we're going to spend some time hearing from VA and share other examples of cost effectiveness of Econsult on our next month's call. And last, just please mark your calendars for this along with the March 30th CME. We are really happy to see such a large number of folks on the phone today, not just from California, but from other states. We thank Terry Fulmer, Mike Curliand, and the UC Irvine team. Thank you, Kathy and Valerie, for joining us today. Thanks so much for all the wisdom you bring in terms of the general idea of Econsult for older adults and then how the mechanics work. It was so helpful to hear from you. And once again, thanks to our sponsors who make our work possible, not only our work in terms of policy and advocacy around reimbursement, but also who help us to put on our annual meeting that we're hoping can be in person this year in November. And we are right at our time, so I'll thank you for giving us your time today and hope to see you next month. Thanks now. Bye-bye.